My work is in big vascular disease epidemiology, I guess big data and vascular disease epidemiology, and I lead a team called VIEW, which I'll talk to you about during this presentation. And I've been working in big data research for almost 40 years, and I want to start with some old big data, and it's also a good news story. This is vascular mortality in New Zealand since the 1950s, and this is men at the top and women down here. And vascular disease in New Zealand in men, where it's more common than in women, peaked in 1967. There was also a little peak here in women in 1967, and it's been plummeting since. And this is basically data that's available, has been available for many, many years. It's just national mortality data is the numerator, and usually census data is the denominator. And we've had this for many years. And it is great news. It looks like I'm almost out of a job, which is always what I've been keen to do. You know, I started in this area in 1980, and it's been a wonderful ride to see this, and I've taken all the credit for this decline. So it's an incredibly good news story, now, but it's not all good news, and I just want to show you some modern big data, and I'm going to come back to this. This starts in 2006. The previous slide finished about 2011. But the good news is that it continues. Vascular disease death rates continue to decline in every group. But this is by ethnicity. And you can see the bad news. This is Māori at the top. Good news, it's coming down. But look at the inequalities in outcome for Māori, Pacific, South Asian, European, and other Asians. So our work has now very much moved away from trying to deal with this disease as a national and international epidemic for everybody, to a disease where there are major inequalities in outcome. And so our focus now is how to deal with these inequalities. The group that I lead, maybe the lead singer, but there's lots of other songwriters in this, is a group called VIEW, which stands for Vascular Risk Informatics, using epidemiology and the web, and I'll tell you why it's got those bits. And our main goal is to reduce inequities in vascular disease outcomes, and there's two ways where our group is focusing on two big areas. One is that we work on vascular risk prediction, and so our goal is to develop better tools so that we can identify who's at the highest vascular risk and then target them with interventions to reduce their risk. And then the second way we're working is that we monitor trends in inequities in vascular disease risk, in risk management and outcomes, and provide feedback to clinicians, providers, policymakers to try to reduce those inequities. And this is our team. I'm the non-Māori director. Māteri Howard is the Māori co-director. We have a team that cover primary care, secondary care. Dan, who's here speaking later, as our social determinants lead. And we also have a Pacific lead, Karina Gray, and a South Asian lead, because along with Māori, Pacific and South Asians have very high risk of cardiovascular vascular disease in New Zealand, and the rest of the team. But I really show this slide just to show that we're very focused on the populations with the biggest problems, and we've tried to bring as many people with an interest in these different groups into our team. And many of you will have seen this, but as you all know, that equality of access or equality of information doesn't necessarily give you equality of outcome. So our goal is to move in this direction, and I guess a lot of our work is focusing on identifying who's at highest risk and providing them with extra care. But ultimately, our goal is to break down the wall. And it's fascinating. I was thinking this morning is that often in public health we say that we want to move from the ambulance at the top of the cliff to building a fence at the top of the cliff. But interesting, in this slide, it's presented in the opposite way as you take down the fence. I thought that was kind of an interesting. I hadn't thought of it before, but this is very much at the public health end. Anyway, we're working more and more in these two areas, both targeting high-risk people and also in the public health area. And so I want to start by just talking about how we've been using big data to improve the accuracy of risk prediction and to target people for treatment who are at highest risk. Some of you know, if you've lived and worked in New Zealand, that New Zealand has been a leader in targeting high-risk people with cardiovascular disease. We were the first country in the world to use risk. This is a chart for identifying who's at high risk. It's based, this is one for women, and it takes into account a number of risk factors, and the colour identifies what your risk is. And it was designed to move away from things like hypertension, which is a meaningless construct, and high cholesterol, which is also a meaningless construct, and focus on people who are at high risk as opposed to have high single risk factors. So we've done a lot in this area. But the downside is that this risk chart came from a study in Framingham, Massachusetts, because that was all that was available when we moved into this area. And a big question, there's been a big question, is how accurate is a risk prediction algorithm that comes from a homogeneous cohort of white Americans in the 1970s? And can we use that, apply that in a multi-ethnic and socially economically diverse New Zealand population in the 21st century? Okay, very important question, And so we've attempted to answer this question using big data, and we established a study called the PREDICT study back in the early 2000s, and I'm just going to briefly go through that quite quickly. What we did is we gave about a third of all New Zealand general practitioners a web-based clinical decision support tool. So that's where the W in view, the web comes from. So about a third of all New Zealanders, mainly in Auckland and Northland, have been exposed, or adults have been exposed to this risk prediction and risk management tool if they go and see their GP. So the GP uses this tool, predicts the patient's risk, and so the clinicians use this as a clinical tool. They're not so focused on the research. They're using it as a clinical tool. But what happens is every time a clinician uses this tool on a patient, a copy of the data goes into a server, to our server. Okay? Now, in the background, anyone in New Zealand who has a hospitalisation or death goes into a Ministry of Health server. And because we're fortunate to have the NHI, this wonderful National Health Index number, we're in a position where we can link those together, create a cohort, create a new chart, and replace Framingham. There you are. In a few minutes, half a minute, I've told you about 15 years of work. And this is our cohort, and this is why it's big data. We started in 2002. We now have actually over 500,000 people, adults from Auckland and Northland in this data set. It's getting up to 80 to 90% of all eligible adults in the Auckland and Northland region of New Zealand. So this is big by international standards, 500,000 people. And just to give you an idea, this is, if you look at the numbers, Framingham, by the way, was 5,000 people. We have 175,000 women, 225,000 men. And if you see here, if you look at ethnicity, Europeans in the order of just under 100,000 to 120,000, Māori, about 50,000, Pacific about 50,000, South Asians about 35,000, and Chinese about 40,000. So these are big numbers for a tiny country like New Zealand. But you need big numbers to do this kind of research well. And this is just deprivation. We're fairly well, we've got a good distribution of deprivation. I'm not going to go into the detail. But the key issue I wanted to share with you is that we've created new prediction equations that, unlike Framingham, which obviously didn't have any Māori, Pacific or South Asian people in it, we can now, in an equation, we have sadly identified that if you're Māori, a Māori woman, you have a 50% higher risk of a vascular event over and above all the standard risk factors that were in the Framingham equation. So this allows us to target better Māori men, about 35% Pacific, about 20% South Asians, depends male or female. And if you're lucky enough to be Chinese or other Asian, you have a 25 to 30% lower risk of vascular disease over about 5 years. So just in terms of a comparison, if you're a smoker, you're about 70 to 80% higher risk. So these are important risks. Now, so to answer the question, is the Framingham equation relevant in New Zealand? Well, in fact, it's not. If it was working well, those blue dots would be on that diagonal line, and they're not. They're not. Whereas our new equation, there it is, perfect. It should be perfect because it was designed in the data set. But this is real. I mean, in a study of this size, you're not really overfitting because you've got 500,000 people in it. So these our new equations, which have just been published in The Lancet, are going into practice now. So that's 15 years of work using one set of big data. So that's some data we get. Now, our second area of work has been monitoring trends in inequity in risk and risk management and outcomes, and designed to feed back. So obviously our clinical tools are designed to be used by clinicians, but this other set of data is also designed to feed back and challenge clinicians, providers, policymakers when you find inequities. And here was the big data I showed you before, the big old data, where you can really only use mortality because it was the only data that was readily available as your numerator, and your denominator was usually census type data. So what we've done is that now, because of the NHI and the ability to link data, we've created a series of national cohorts that we call varians. I'll tell you what that stands for, but they're basically, other people would call these health service utilization cohorts. They've also been called health tracker cohorts. But where this came from is when we started PREDICT, we created a data set of risk factor data in primary care, and then we used to go to the Ministry of Health every year and ask them to link our risk factor data, blood pressure, lipids, etc., to hospitalizations and deaths. We were also able to use, there's a national virtual diabetes register, there's a regional laboratory data set, and there's also a primary care enrollment data set. There's a drug data. Every drug that's dispensed in New Zealand that's subsidised is also in a national database. So our access to these large national databases started by us linking it to our primary care database. PREDICT, that's PREDICT. We have another cohort that I'm not going to talk about at all today called ANZACS, which stands for the All New Zealand Acute Coronary Syndrome Quality Improvement Project, which actually does a similar thing. It uses the same web-based platform that we have in primary care, and it uses it in secondary care, and it links to all of these databases. But what we realised after working with these data sets for about 5 to 10 years is, and other people have realised this as well, we weren't the first ones to do that, is if you linked all of these databases together, you could create a national database of pretty much everybody. And I know many of you have done this with, and we call this, for us, it's called VARIANS, which stands for Vascular Risk in Adult New Zealanders, because our focus is vascular risk in adult New Zealand. So we've joined all these data sets up, and they allow us, one, to create a new denominator, so individual data. So rather than using a census denominator, we can now create an individual person denominator, and any numerator data we can link directly. And the sort of things we've been doing is, and I'm sorry this is a bit blurred, but we're now looking at age standard, we're looking at death rates, separating to people with prior disease and without prior disease, because that's, from our perspective, are the trends the same in those with and without prior disease, because that actually tells us a lot about treatment effects. I've shown you this slide before where we can look at trends in by ethnicity, where we don't have numerator-denominator bias, so we can be much more confident in our data. And here's some data by NZ DEP, by deprivation. We're starting to look at deprivation, so trends by deprivation. Again, good news, it's all coming down, but you can see these huge inequities, quintile, NZ DEP quintile 5 at the top to quintile 1 at the bottom. So the kind of things that you can do when you can link the numerator and denominator. Here's a study where we've looked at drug use. So in terms of feeding back to the sector about whether, in this case, sorry, it's a bit blurred, but whether, in this case, Māori Pacific, Indian or other, get the same access to drugs. I don't want to go into detail, but this is the sort of thing we do. And an exciting new study that is about to be published, led by Sunila Mehta, we've now actually created a new risk prediction equation where we've only used national data. So we've just used the routine national data to create a risk prediction tool we call a policy risk prediction tool. So we can, at the press of a button, give every New Zealander cardiovascular risk. Don't have to do it through primary care. So it means that when we look at treatment, at the moment, this is just Māori Pacific South Asian, we can now stratify that by risk to see if it's actually giving the right people treatment. And this equation's it's about to be published in the International Journal of Epidemiology. I'm not going to talk about this, but the next step is Varian's IDI. So we've been working just with health data sets, but other speakers will talk about education, census, arrival departure databases, but we're going to be moving into an even more granular field. We've started looking at the IDI from our perspective. We're finding that we can move our work from just the health populations into the IDI. And I won't have time to go into this, just to say that we think the IDI, or we've demonstrated the IDI, is the best denominator to use for our research. It's better than the census, it's better than the health contact data. So that's where we're headed with this data, moving across there. And I guess most of our work is in here and in here. And there's absolutely no doubt that the great access New Zealanders have to big health data is really making, it's an exciting time for me as an epidemiologist. Stuff that I could not have done 20 years ago that we can do now. It's exciting times.